the frequency of feeds. Is this baby getting 100% of his or her nutrition from mom? Is this baby nursing every 2 to 3 hours? Or is this a baby that maybe just nurses once a day? In that instance, potentially an older baby that nurses once a day, the medication that mom uses in another time of day may not impact the one time of day that they feed. So we need to consider that. We also have to think about the mother. Does the mother need this medication? Just yesterday I was at the milk bank and we were talking about how mothers are starting to want to use essential oils and take them orally. And this is something that as a pharmacist I don't know much about, honestly. So we were talking about, the safety of consuming essential oils and potential impact on the baby. Is that something that the mother necessarily needs to do? Probably not. But there are many medications that the mom could potentially need at one time or another. And so we need to consider how important it is that this medication is taken at this time. And we also want to consider the ability of the mother to take the medication properly. If we instruct her to take it, is she going to take it the correct way, or is she going to take extra doses, or in some other manner that she should not be consuming it? And then we also want to consider the drug. Now, I realize that it's not all pharmacists in this group, and so I am giving you some information about medications with the hope that you can work with the pharmacist on your healthcare team, and having some knowledge about some of the different factors that impact whether or not a medication goes into the breast milk may help you work a little bit better with the other healthcare professionals on the team and with new mothers. So some of the aspects we're going to talk about the half-life of the medicine, the molecular weight of the medicine, and protein binding. Those are just a few factors. It's not everything, but just a few things to get us started. Oh, sorry about that. So the half-life is the time it takes for the concentration of the medicine in the body to be reduced by 1/2. Drugs with a shorter half-life are a better choice for breastfeeding mothers. So I have an example here for you with ibuprofen and naproxen. Now, many of you may know that ibuprofen is a better choice for breastfeeding mothers, and as you can see, it stays in the body for a shorter amount of time. It has a shorter half-life, so it's a better choice. And now with these parameters that I'm showing you, one parameter is not really our only deciding factor, but I'm showing you some examples so that hopefully you can see why one parameter might be important. Protein binding. So drugs can bind to protein in the blood. Low protein binding means that a drug is more likely to be present in the breast milk because there's more free drug. If it has a higher percentage of protein binding, there's not as much drug available because it's bound up to the protein. So lower percentage of protein binding, more likely to get into the breast milk. Higher percentage of protein binding, less likely to get in the breast milk. So if we look at two antidepressants, here is escitalopram and sertraline. So escitalopram, the brand name is Lexapro, and sertraline, the brand name is Zoloft. Now, actually, both of these are typically fine to use in breastfeeding mothers. But when we're looking just at the parameter of protein binding, we can see that escitalopram is 56% protein bound, which means almost half of it is more available to go into the breast milk compartment. And then sertraline is 98% protein bound. So the third column, the column on the right, is relative infant dose. And my next slide will explain what that means. But essentially, that is the exposure that the baby gets to the medication adjusted for the baby's weight. So with escitalopram, almost half of it, as we said, is available to move into the breast milk compartment, and it has a higher exposure rate, 5.2 to 7.9%, higher exposure rate of the baby to the medicine. The sertraline is 98% protein bound, and so there's a very low exposure rate for the baby. So relative infant dose, just for completeness, this isn't probably something that you absolutely need to know, but it's a value found in literature that represents the relative exposure that a baby has to a medication. And generally, less than 10% is what we're looking for. But there are exceptions to that. One of those being if we have a medication that we would give the baby anyway, if you have a greater than 10% relative infant dose, it may not be that big of a deal. So in this case, both of those antidepressants, I'm going to go back to the previous screen, both of those antidepressants have a less than 10% relative infant dose, which again, we don't want to go only by one guideline, but you can see that the protein binding on the sertraline being higher, less of it is going to get through to the breast milk. Thirdly, molecular weight. So drugs that have a low molecular weight may cross into breast milk more easily. Drugs with a high molecular weight may cross more slowly. It may take them a little bit longer to move across. So as an example, heparin has a molecular weight that's very large, of 12,000 to 15,000. Very little would cross into the breast milk. If we compare that to another anticoagulant with warfarin, so heparin versus warfarin, heparin has a huge molecular weight, and so that keeps it from really getting very much into the breast milk. Warfarin has a pretty standard molecular weight. It's a little lower, right, 308. So that one should be able to cross more easily. However, warfarin has 99% protein binding, so it's very, very highly protein bound. So very little of it gets into the breast milk. So as you can see, this illustrates that you have to take into account multiple factors, and that will impact how well the drug gets into the breast milk. So a word of caution on these parameters. The parameters presented here are not the only things that can impact the transfer of medication into breast milk. There are other things, such as how high of a dose we have, so something with a very high dose, or if a patient is taking extra doses, as I mentioned. The frequency with which it's given is also important, and so if the mom is only using something once a day versus using it every 4 hours, that type of thing, there might be more exposure then. And then how well it is absorbed. So the medication needs to be absorbed in order to move into the breast milk. And it also needs to be orally bioavailable, which means the baby's gut bacteria could potentially break it down, and then it wouldn't be as much of an issue. So drugs also can impact women differently due to differences in metabolism and tolerability. So what I mean by this is we can look at the literature and see, oh, this should be fine, this should be fine, but some women just have different responses to medicine. You can think of it like some people are allergic to antibiotics and others can take them just fine. For some people, they have a side effect maybe that you don't have when you take a medication. For example, Benadryl. We usually say Benadryl makes people tired, right, when they take it, and it's in sleep aids such as DQuil. But some people don't really get all that sleepy with Benadryl. It doesn't work as a sleep aid for them. And in fact, when given to children, Benadryl may make them hyper. So as you can see, medication can impact people differently, and we need to keep that in mind. When speaking in terms of lactation, we see variances in milk supply. Sometimes a mom will take a medicine and it has a huge impact on milk supply, but we haven't seen that with another mom. Some examples of that might be with pseudoephedrine for a cold. Sudafed is a decongestant, and mothers will often experience congestion during pregnancy and afterward as well. And while Sudafed is used sometimes in pregnancy, and that can be okay, it can have bad impact on milk supply, reducing it by up to 25% in as little as one dose. So not all mothers will experience that drastic of a drop, but it is a potential. So now let's talk about a couple of classes of medicine that are commonly seen for breastfeeding women. And there are a ton more needs than what I am describing here, but I just wanted to go through a few of them to provide some examples to you. So contraception, and if there's one thing that I've learned from being amongst the lactation professional community is that contraception can be a really hot topic to talk about, a really passionate issue for some. So the Academy of Breastfeeding Medicine actually has an excellent protocol available on contraceptives, and it's very easy to read, excellent resource to utilize. I put a very, very brief summary here of the contraception protocol. They describe the lactational amenorrhea method in the protocol. So lactational amenorrhea meaning as long as the patient hasn't had a period, the baby is less than 6 months old, and the baby's exclusively breastfeeding, then lactational amenorrhea is a very successful way for birth control. It also talks about delaying contraception until 6 weeks postpartum. So we should not be having our moms to take any contraceptives. They shouldn't be receiving a shot, getting an implant, any of those things until at least 6 weeks postpartum, at which time progestin-only contraceptives are preferred for breastfeeding mothers over combination contraceptives. And it does say in the protocol, the worry is that the combination contraceptives will reduce milk supply. It also says that early contraception before 6 weeks with a progestin-only or a combination product is not recommended for breastfeeding mothers. So they do say in there that using a progesterone-only form of birth control before 6 weeks may adversely impact milk supply. So this is important because I know that just in practice that we've seen, some professionals don't feel that way. They feel like it's more important to give the mother a contraceptive solution right after delivery, but we know that this can impair lactation potentially. And so we really want to hold off on any sort of hormone intervention until at least 6 weeks postpartum. So here are some other considerations when looking at contraceptives for a patient. We want to consider adherence, which is, of course, very important with all medication, but with contraceptives, if they're not going to take a pill every single day, then we need to probably think of another solution for them. The administration route could be an issue. So the pills, like I said, or an injection or an implant, a vaginal ring, a patch, there's many different forms of birth control that can be utilized. And so we need to consider what is going to be the most realistic and beneficial for them. The mother may also be interested in the birth control that she used before she got pregnant. Perhaps she liked that, she felt like it worked fine, and she wants to utilize that again. Now, if that is a combination contraceptive, which is a very common form to use, then we need to make sure she understands what the risks are to milk supply. And then the fourth consideration on here is she having any supply issues now? Is she pretty even with meeting her baby's needs? Maybe she wants to hold off a while on moving to a combination contraceptive until she's, a little further along in her breastfeeding journey and isn't as worried about supply. So those are just some of the considerations that we have when we're thinking about contraceptives for patients. It's really, really important that mothers hear about contraception and their options and the potential impact on breastfeeding before they need to make a decision on it. Ideally, this information should be made available prenatally just because, it's so hectic in the hospital after delivery. But we need to do a really good job of educating because I can't tell you how many times I've heard of moms that get a depot shot or get, start taking oral tablets or whatever the case may be, and they're a combination of progesterone and estrogen, and they did not know that it was going to impact their milk supply. So education is really, really important. I understand that at some practice sites, this may be a little bit of an issue. And so consider sharing the ABM protocol, the Academy of Breastfeeding Medicine's protocol at your site if it's not currently being followed. Certainly a very important thing for our patients. Next, I wanted to talk about antibiotics. Many antibiotics are safe to use in lactation and would be considered safe to use in the infant as well. Some of those examples are amoxicillin, ceftonir, azithromycin is another one that we see quite a lot. We would use it in the baby. So the very tiny amount that the mother is going to pass through the breast milk to the baby is typically not a problem. Some antibiotics may be acceptable if benefits outweigh the risks or under certain conditions. So the examples that I have of that would be sulfamethoxazole trimethoprim. The brand name for that is Septra or Bactrim, and ciprofloxacin. Those are two examples that could potentially be okay, but it just depends. Sulfamethoxazole trimethoprim, caution should be used, or we should not use this one at all, within the first month postpartum due to the risk of hyperbilirubinemia. So certainly if you have a baby who's jaundiced, a baby who's premature, we want to be extra careful that typically we don't, even in a healthy baby, really want to use this for the first month at least postpartum due to that risk. Typically, another antibiotic could be selected. Another example would be ciprofloxacin. Ciprofloxacin can cause tooth discoloration in infants, and while that's probably more cosmetic than anything else, it's still kind of undesirable, and probably we could use another antibiotic. There's a case report of pseudomembranous colitis, but that doesn't seem to be a typical, I mean, it's certainly not a typical thing with ciprofloxacin. It's just a possibility that we want to be aware of. And antidepressants. So antidepressants, it's very important that when mothers are in need of an antidepressant, if they have postpartum depression or anxiety or another mental health condition that necessitates the antidepressant, it's crucial that they get the treatment that they need. We really don't want to stand in the way of them getting what they need. Of course, we have to make sure that the antidepressant is safe in lactation, but there are plenty of options available. And most of the common antidepressants are actually safe to use in lactation. Some of those would be SSRIs. Those are the ones that you hear about probably most often in terms of antidepressants. So sertraline, the brand for that is Zoloft. Paroxetine, the brand for that is Paxil. Paroxetine is not typically used in pregnancy due to the risk of cardiac defects, but very little of paroxetine gets in the breast milk, and so it could potentially be an option for a breastfeeding mom. Citalopram, the brand for that is Celexa. Escitalopram, the brand for that is Lexapro, and fluoxetine, which is Prozac. Those can be used and may also help with anxiety. Now, fluoxetine has a really long half-life, so that's probably not my favorite choice out of the ones here, but still could potentially be used. Additionally, bupropion and venlafaxine are other options that can be used. And for mothers that use venlafaxine, the brand for that is Effexor, by the way, in pregnancy, it is preferred to use venlafaxine postpartum as well. They should continue it, and to breastfeed so that the baby hopefully does not undergo any type of withdrawal syndrome with the venlafaxine, because that is a possibility if the baby is exposed to venlafaxine in utero, that they would undergo withdrawal if they have no exposure to it after delivery. So continuing to take the venlafaxine and for the mother to breastfeed is actually what would be best in this case. I also wanted to include in here that the FDA has recently updated the pregnancy and lactation labeling guidelines for new medications that are coming out. So there's new requirements, and that became effective on June 30th of this year. The package insert for medications now must include 3 sections, one on use in pregnancy, one on use in lactation, and one on the use of the medicine in males and females of reproductive potential. So this is an important change because one of the barriers with giving mothers good advice on whether or not a medication was okay was that there was not a whole lot of labeling regarding that. So now there's a designated section. I don't know that there will be much additional study, hopefully so. You know, that's always a barrier, getting good study data on lactation and medication. But those 3 sections are now required to be in the package insert. Now, which drugs does this affect? This affects all new drugs that are being approved from June 30th and on. So if a drug was approved last year, then they are in, under the second bullet point, they're going to be phased in gradually to have this labeling. So they don't have to do it immediately. I think they have 3 years to catch up and put it in there. But if they're approved on or after June 30th of 2001, they're going to be phased in gradually. Now, this new labeling requirement does not impact over-the-counter drugs, and it's not mandatory for drugs that were approved prior to June 30th, 2001. So as you can see, a lot of medications won't necessarily have this labeling, but still, it's an important step so that we have better information included in the package insert. So now I wanted to talk a little bit about the pharmacist. Pharmacists are in a great position to help nursing mothers. In the hospital, now I'm not a hospital pharmacist, but have trained in a hospital before. So in the hospital, pharmacists are dispensing medication for labor and delivery floors and the postpartum floor, and should check to see if the mother is or will be nursing. Now, I'm sure there are a lot of things that are just a set protocol, but if there's anything out of the ordinary, they should keep that in mind. In the community pharmacy, which is where I work, pharmacists should ask if a mother is nursing when filling her prescription. So, and I apologize for the spelling error on prescription there. So if a mother is dropping off a prescription and you see that she has a baby with her, it'd be a good thing to ask. Or if she is of the right age to have children, you may ask if she has any health conditions such as pregnancy or breastfeeding, things like that. The community pharmacist is also available to answer questions. And so we do get plenty of questions from mothers that have concerns about breastfeeding because the pharmacy is open later than the doctor's office is. Some of the pharmacies are open 24 hours, and so we know that questions don't always happen at the most convenient times, and mom may come in and have a question if she can take something while she's breastfeeding. She may also have questions about where she can get her breast pump now that they are all required to, all insurances, are required to pay for a breast pump for nursing mothers. We do get questions all the time because moms are trying to figure out how they can navigate that and get their breast pump through their insurance. So those questions come up frequently. The community pharmacist also is in a great position because we see mothers during the postpartum period before that 6-week follow-up appointment. So all during pregnancy, ideally, if she's seeking prenatal care like she should, the mother is going to be seeing a doctor on a regular basis, or a nurse practitioner, midwife, someone that she can ask questions of if she needs medications. But after delivery, the mom is sort of left hanging out there until her 6-week follow-up appointment. She's not getting all the monitoring that we're giving to the baby during that time. So she can come to the pharmacy, ideally, and ask a question. We usually will see the moms because they're getting their medication filled postpartum for pain medicine, stool softener, those types of things. So this is a great opportunity for us to provide continuity of care and encouragement to mothers following delivery. However, I don't think it's any secret, there are barriers to pharmacists being helpful for providing lactation advice to patients with regard to medication use. So to be clear, pharmacists are not providing lactation advice in the way that lactation consultants are, but providing advice with respect to what medications would be okay. Pharmacists typically do not have extensive training in medication use during lactation. So from personal experience, that was certainly part of our training in school, but not a huge part, not a big emphasis, because there are many, many things that are covered during pharmacy school. And I think that this is a barrier that we see in other health professions as well. For nurses, physicians, other healthcare providers, they probably don't have a lot of training on the impact of what they do and on lactation. So additional training would be beneficial for pharmacists. To help mothers, pharmacists need to know what to ask about and where to look for accurate information. So they need to realize that the consultation has to be individualized. You can't just say, you can always use this antidepressant or never use that antidepressant. We really want to individualize the consultation. And they need to know what resources are going to be good in order to get the right information. So if you are not a pharmacist, let's say you are a lactation consultant at a hospital, why would you want to work with the pharmacist? Well, pharmacists are easily accessible. And if you can work with a pharmacist to help a mom, that may empower the pharmacist to be able to help additional mothers. Perhaps in the interaction, the pharmacist will learn something and be able to help additional mothers that present with similar questions. Also, it's beneficial to work with the pharmacist because we want to provide great continuity of care to our patients. So they need support all the time, whether they're at the pharmacy or at breastfeeding support group or at the doctor's office or whatnot. So continuity of care is essential, and starting a conversation with the pharmacist could be a way to help with that. So this is a little uncomfortable, but if the pharmacist was not helpful when you are working with the pharmacist and trying to help a patient, what can you do? Well, you can offer resources to the pharmacist. So you might see if they have access to Medications in Mother's Milk, which is the Hale book. That is a good reference to use, a lot of great information, and I cited it earlier in this presentation when talking about drug parameters. So set up in a way that is similar to a reference book that pharmacists have often used before. So that may be a good option. Another option is LactMed. So LactMed has a free mobile app that can be used, so the pharmacist could just download that app for free. And it provides some good information about the use of medication during lactation. You can also refer the pharmacist to the infant risk hotline or give them that number to keep in case. And that is a number that I've used when I can't find the information in my usual references, then I'll call that hotline to see if they have the answer for me. So it's not that pharmacists don't want to help, but they may just not have enough training or enough experience to know the answer to the particular question that the mom is asking. So the second main bullet point on here, I would ask you to provide carefully, but providing helpful feedback can be good. So let's say that you are working with a pharmacist to, get the right medication for a patient, and she ends up getting what she needs. You might let the pharmacist know, hey, the patient ended up getting what she needed, so, thank you, that was a successful interaction, something like that. Or if it didn't go so well, pharmacy is a business as well, and I'm sure pharmacists, we all want to help our patients, but we also don't want to lose our customers. So it would be good to provide helpful and useful feedback if the interaction didn't go so well, and especially if the information was incorrect. So if you can provide that in a way, that feedback in a way that's not overly passionate, but just sharing information to help them improve for next time, that would be good. So I put that in there, but ask you to be, not delicate, but be professional in providing that feedback, because sometimes it can be very upsetting. And when I hear about a mom getting bad medication advice, who's a breastfeeding mom, I get really passionate and upset about it too, because it's unnecessary that happens. But if we don't correct those things, if we don't share information and resources, then we're not going to get better for next time. So that is why I put that bullet in there. So not all medications are safe to take, in summary of what we went over before. Not all medications are safe to take while breastfeeding, but many medications are compatible and can be safely used. We don't want to make any assumptions that, this medicine never can be used at all. There may be a few medicines that fall into that category, but we want to make sure that we're looking at the individual patient, looking at the information each time. And even though I counsel a lot of breastfeeding mothers, I still look stuff up a lot to make sure that I'm providing the most thorough information that I can. Also, we need all members of the healthcare team on board in order to help mothers to meet their breastfeeding goals. So at this point, I wanted to allow some time at the end to do questions, and I hope that I'm utilizing this system correctly to do that. But if we're able to do any questions or any, I guess, experiences that people on the call want to share, I would like to help you to work with the pharmacist in your healthcare team as best we can. So if you have any questions, I guess I would open it up for that.
Yeah, and this is Chris. Can you hear me now, Amy?
Yes, thank you.
Okay. I have we'll wait, and you can type your questions in the chat place. If you go down to the bottom of your control panel that's on the right-hand side of your screen, there's a chat box at the very bottom, and feel free to type questions in there. If you want to make a comment, you can raise your hand, and we'll see if we can do that also. But okay, we have a question here. Can you see the questions, Amy, or do you want me to read them to you?
I don't see them.
Okay, I'll just read them to you. The first one is, are any smoking cessation products okay for breastfeeding moms?
Oh, okay, that's a good question. So can they use anything for smoking cessation?
Right.
Yes. So it would be okay to use, I mean, ideally, we don't want to expose to any more nicotine. You know, ideally, we would use something that's not a nicotine replacement product, like counseling. But realistically, there's better success with the nicotine replacement products. And when you think about it, most things are going to be better than smoking. So when you think about it in terms of, is this better than if we just left her continuing to smoke while breastfeeding? We know that a smoker who breastfeeds, it's still more benefits to the baby, as long as she's not smoking while she's holding the baby, than if we're formula feeding. So there's still more benefits to breastfeeding. Now, in terms of utilizing nicotine replacement products, that is typically it's considered to be okay. In the Medications in Mother's Milk book, the Dr. Hale book, he rates drugs in there on a numbered system. So lactation categories is what he calls them. So L1 through 5. L1 being usually the best choice, and L5 being contraindicated or absolutely do not use. So I didn't put the lactation categories in here because they are specific to Dr. Hale, but I think that when you're utilizing his reference, it is a good thing to be aware of, and he has a great forward in the beginning of the book on that. So with that said, the numbered categories, this is an L2. So it's considered pretty safe. Now, in the book, it has a long explanation of studies that have been done looking at the gum, even e-cigarettes in here, and you know how that has impacted moms and babies. So there was a study with a nicotine patch, and it didn't note any pediatric concern. So it looks like in his book, that's probably, the patch is probably the way to go. But nicotine replacement products would be an option. Also, bupropion, I had mentioned, as an antidepressant that could be okay, and that is also used to help with smoking cessation. So that is another possibility. So probably those two I would look at first, because we know if they have some sort of pharmacologic intervention, that smoking cessation is going to be a bit more successful, quite a bit more successful, than if they just do it cold turkey or, you know, counseling but no medication at all. So I would say, generally speaking, that nicotine replacement is fine, but you would want to look at your individual patient and how fragile the baby is and the factors that I mentioned earlier.
Okay, great.
That was a good question.
Yeah. The second question is, have you heard of the website app safefetus.com?
I have not. What is it?
I don't know. It's Amber. Amber, if you could let us know. Wait, let me try to unmute you. Amber, can you tell us a little bit about that? Amber Lamb? Oh, I don't think we can, okay. We're not hearing you, so.
Oh. Okay. What is that app again?
It's safefetus.com.
Safe fetus, like unborn baby fetus?
Right, right.
Okay. I was not aware of that. I'll have to be, I'll have to make myself aware of that. But I pulled it up now.
Yeah.
So if that has an app that is free on it and it's a good source of information, then that might be another option. I mean, understandably, the yeah.
Oh, Amber typed something in the chat. She said,
okay.
It's a site run by MDs and pharmacists that has a resource for looking up drugs that are safe or unsafe to use during pregnancy and nursing. So it's definitely something to check out.
Yeah, excellent. It's good to get more resources.
Yeah. Okay, there's another question from Sandy Arnold. She says, is there a way that this webinar can be used to educate pharmacy students at Butler, Purdue, etc.? And I think you could speak to that, Amy.
Yeah, that's a good question. So I do some lectures at Butler. I don't currently lecture at Purdue, although have spoken with them about that, and there's interest because I take students on rotation from Butler and Purdue. So in the last year of pharmacy school, they have rotations, and they do usually 10 one-month experiences, and I take students on a women's health rotation as well as a general rotation. And so there is a lot of interest from the students in learning this information. So I definitely speak, I haven't really spoken at Purdue. I speak quite a bit at Butler, and I do that also. I run our summer intern program. I didn't do it this year because I just had a baby, but typically I run our summer intern program and do a lecture on it during our summer intern program, lecture on it to our students that are on rotation with us at Walgreens, and I have been involved in 3 CEs now for pharmacists on medication and lactation. So been trying to do my part to help pharmacists to get better information. We had a really great online CE that was free, that was 1 hour, but it has recently expired. And so I'm looking into getting, doing another online CE, because that's a great option for pharmacists to do it, whenever it's convenient to them, as opposed to when you do a presentation and they have to be live in attendance. But yeah, ideally we would do the training, a lot of training in school so that we could get everyone before they're out and practicing. But it's still important to talk to our pharmacists that are out there now and try to get them more education on medication and lactation. So yes, I'm trying.
You're doing a great job, Amy. I believe that you've also done some in-services with Walgreens pharmacists. Is that correct?
Yes. So I provided, when we had our CDC grant a couple years ago, I bought handbooks for all the Walgreens pharmacies and our nurse practitioner clinics that we have. And so I provided all of them with a handbook, and during a meeting we went over a training on how to utilize those books. I had them look up drugs with me and make sure they knew how to do it. So that was, I thought, a good step for us. And then I do get a lot of calls from other Walgreens with questions. So yes, we are trying.
And we have recorded most of this presentation. We had a little bit of problem getting it started right at the beginning, but I would imagine that this will be very helpful. If you know of a pharmacist, you could direct them to the IPN site and they could listen to the recording of this. I have a question. Do you have any suggestions? Well, I guess you kind of addressed it for hospital pharmacists that we work with. If I work in a hospital, and suggestions for them on CEs that they can go for. I guess you already addressed that. I'm sorry.
Well, no, it's okay. It's
anything
okay.
else?
I mean, Butler does a yearly CE symposium, and so that's like on their campus. It's a 2-day CE event, and I've presented there before, and I'm on their committee, so there's always a women's health topic that's being presented at the CE symposium. That's a live event every June. And, just, I guess, making sure that they're aware of CE opportunities as they come out. If I can get another online one developed, then I would certainly share that with the Breastfeeding Coalition so that we could reach out to the pharmacists in hospitals, community practice, wherever they are, to get them that information. So, yeah, it's just a matter, I guess, of keeping your eyes and ears open, because pharmacists, usually we get bombarded all the time with those like CE dinner things through drug reps, and I just ignore those. I get most of my CE online, so that's why I think doing an online CE would be a great way to outreach to pharmacists.
Yeah, I agree. We have a comment about the safefetus.com site. Someone, Erin, commented that she searched through a few of the drugs that you've talked about today, and they don't always give out good information. For example, Zoloft states it's excreted into milk, unknown effects on nursing infants, and Prozac states excreted into milk can cause toxic effects on newborns, such as vomiting, watery stool, etc. So might not be the best app to download. I know the LactMed app that Amy mentioned is free, and generally has the meds I've looked up on it are good information there.
Good, yeah, and I think of all the references, Dr. Hale's reference is probably one of the more permissive ones. He's very much in favor of, safe medication use, but possibly, since he's got so much information in there, he's a little bit more permissive with what is okay. Personally, I tend to more agree with what he has listed, but in the absence of having good information, I can understand why a pharmacist would say not to take something, because they certainly don't want to cause any harm. So,
yeah. Oh, Amy, do you want to say anything about the surgery center letter that we're working on, or?
Yeah, I do. I can talk about a couple of medication-related things going on. So Chris has been so tireless in working on our surgery center letter that we're distributing. So the idea of this letter is to provide good information to surgery centers so that when they have a breastfeeding mother that is going to get a procedure done, that they provide accurate information and don't tell her that she has to pump and dump for 2 weeks after surgery or something totally insane. So we want them to provide good advice and also to make their facility more breastfeeding friendly so that mothers who are patients can remain with their baby as long as possible before they go into surgery, and then hopefully, as soon as they're awake, be reunited with their baby to feed the baby. So the Academy of Breastfeeding Medicine also has a protocol, like they do for contraceptives. They have a protocol for anesthesia and pain medication. And so we have cited that protocol in there, utilized information from there so that they have a good resource available, and we're going to outreach to the surgery centers with this letter. And the letter also provides some good resources if you have a mom that needs additional resources, like she doesn't have a pump, but now she's going to have to pump and dump. Where can she go to get that? Things along those lines. So this may lead to some more outreach opportunities, but right now this letter, we're also partnering with the State Department of Health on it so that it will be more of a health bulletin and hopefully be signed by, is it Dr. Adams?
Yes.
Yes, yeah. So that is the goal with that.
Yeah, stay tuned for more announcements about that on the Facebook page or in Tina's newsletter. We'll let you know as soon as it's available, and I think it will be really helpful. And in the future, we hope to have also something for radiology departments at a state level, from the state health department. So we're excited about future initiatives also. So I think we're almost out of time, and I appreciate everyone's attention and interest in this. As far as the CEUs go, do they come? I think they'll come in an email to you. Yeah. So let us know if you do not receive that within the next week or so. I have one more announcement about a not a webinar. It's a in-person workshop that takes place tomorrow or this Thursday, the 23rd, in the evening, and Friday during the day, and it's a tongue-tie the tongue-tie task force has a conference with Dr. Bobby Gahary from Portland on tongue-tie treatment, and so check out the IPN site if you want to register for that, and do it soon because it is filling up. Oh, okay, so I think that's all I have as far as announcements, and we'll be back in 2 months with another webinar, and next month for the community webinar at the same time and date, or day of the week. Thank you. Bye.